Let me try that. So, hi everyone. Today is March 1st, and this is a Kidney Month. And just want to welcome everyone to this very special webinar that we have today. And it's going to be on kidney transplantation. But besides being Kidney Month, it's also Nutrition Month. So, I want to shout out to all our dietitians that play a very significant role in our patient outcomes and quality of life. And it's also the social work month as well, and they have a very significant role in both dialysis and transplantation. So with that, I'm going to share my slide deck, and here we go. So it's that those are my titles. The topic today is going to be, I just want to point out this green ribbon. This is a campaign that was started at UCLA Health under Core Kidney Program. And one of the pioneers in this is Brandy, who's going to be here with us today and co-moderating this session. And the other one was Ravi Pojwani, along with the whole Core Kidney Program that participated. Disclaimer that all the information that will be shared today is only for information. Please do not make any changes in your care till you speak to your healthcare providers. And this is our Circle of Core. This is a program that we set within the core. It's made of wonderful people who volunteer their time. And the whole idea is to provide support and advocacy for our kidney patients, their family members, and caregivers. And a lot of them are participating here today in this program. This is our contact information. This is a direct line. If you want to email us, you can email us at Core Kidney. Visit our website too. But I do want to, I've never asked this in the past, but please do visit us on Facebook, like us and follow us, because I think that is important in getting more messages out to the community. So this is our Facebook, and we also have an Instagram page. And today we have our elite group of faculty that will be participating. Let me start with right in the middle. We have Dr. Sarkar, who is our transplant nephrologist for the Core Kidney Program. Then we have Brandy, who is our big kidney advocate. Nanette Zumwalt, another huge kidney advocate, kidney recipient. And a lot of both of them have other titles, very successful career women as well. And this is something that they volunteer their time to. And our two special guests today that we have had on our program in the past as well, big supporters, amazing people, is Jill and Bethany, and they are transplant coordinators. And one thing that I always say to any patient who is looking for a kidney or is going to a kidney transplant program, their quarterback is their transplant coordinator. It's not their nephrologist. It's not their transplant nephrologist. It's their transplant coordinator. So their number should be anywhere that you access to, whether your fridge, notebook, phone, their information and contact. And we'll be discussing why it's so important to update changes that are happening in your life. So with that, I'm going to hand over it to Jill, and Jill will give a brief introduction about herself. So the way the program is going to work, we have few slides. We have Jill presenting her portion, about 7 to 8 slides. Then Bethany will go over her slides. And then we want to make it very interactive. So there'll be a lot of Q&As. We already have a whole bunch of questions that have been sent to us. I'll be asking them. But if there are other questions, please put them in the Q&A section. And if we are not able to answer them today, we will definitely get back to you. I also want to mention today our focus is going to be on transplant evaluation. We are also going to have a second part on post-transplant, in which what to expect once you are transplanted. And then the third one is going to be on living kidney donation. So with that, Jill, you can take it from over here.
Okay, and thank you, Dr. Rastogi. So thanks everyone for being here this evening. I'm going to be going over some information that can help you go through the evaluation and kind of know what to expect while you're on the waiting list. I wanted to go over some information, just, what is kidney transplant, some basic criteria, And so I guess let's get going. Who's going to be forwarding the slides?
I will, Jill. So you just
Okay, so yeah, we can go to the next slide then. So kidney transplant is a form of kidney replacement therapy. Dialysis is also, but some people may really have a greater benefit and longer life after kidney transplant. So that's why it's really important to look into it, and the sooner you're transplanted, the better. This surgery is going to provide you with a new kidney to do the work that your own kidneys are no longer able to do. Usually we don't take out your native kidneys, they stay there, and then you just get that extra transplant kidney put in. And just so that you know, kidney transplant is considered an elective surgery. So that's why we have you go through this evaluation process and really see, if there's some risks that may outweigh benefit of transplant for you. Next slide. So we want you to go into the transplant process with kind of your eyes open and understanding kind of what you're getting into. Transplant is, you go through a surgery, so you're going to have some surgical risks and also some risks from the medications and the immunosuppression that you're taking for the surgery. Surgical risks, of course, bleeding, some wound infection. You're likely to have some pain after surgery. Some people may have a urine leak because we're hooking up a ureter to your bladder. And as with any surgery, you can have some clotting, blood clotting problems and some anesthesia risks around the time of the surgery. Medically, we're wanting you to take immunosuppressive medicines to prevent rejection, but those medicines, if the levels are too high, they can also increase your risk for infection. So that's why it's really important that you make sure you come to your clinic appointments and take your medications as recommended to you by the transplant doctors. We're watching you very closely in the beginning to get those levels just right. And so it's important that you work with the doctors and really, do what you need to do to take care of yourself, and know what your risks and know what your medications are so that you can do the best for yourself. These medications also in the long term may have some risks too. Some people may develop certain types of cancers long term. Some people may develop problems with their blood sugars, and we call it post-transplant diabetes. Some people have different risk factors as to who may be more likely to develop these things, but it's really important for you to understand what's going on, what medicines you're taking, and really be an advocate for yourself. And then also, people that are going to help you after transplant, they'll be there alongside to help as well. Some people may get a kidney that, had a little hard time in the beginning and may, not be ready to work right away. And that's what we call delayed transplant function. Some people, depending on what caused your kidneys to fail in the first place, you could have recurrence of that disease in the transplant. And the doctors will go over that at your evaluation so that you understand, if you have one of those types of kidney disease. Also, medication side effects are, something that unfortunately, only you can help decrease the risks for by taking the medicines as you're instructed and communicating, any issues with your doctors, because these medicines you have to take for the life of the transplant, and really, working with the team and being your own advocate is going to be very important for that. Next slide. So this is just kind of a little bit of an overview of the transplant journey. The evaluation and referral are kind of the jump start. And usually, unfortunately, now our referrals, it's taking some time for us to get you to get through the authorization process and then get your appointment, just because we have so many people wanting appointments. Also, evaluations, we try to get you through that. If you can, be working with your physicians, get a stress test, maybe an ultrasound before you come to your appointment, that's helpful. That'll, move you along more quickly. But hopefully, we can get you through the evaluation, and if you're a good candidate for transplant, we'll get you listed, usually within, 9 months to a year. And that all depends on how quickly, you get your appointments taken care of and do what you need to do. Once you're on the waiting list, that's another kind of unknown, depending on how long you've been on dialysis, if you have a living donor. All of those things can impact how long you're going to wait for a transplant. Surgery, just to expect, maybe 4 to 5 days in hospital, but if there are some complications, it may be a little bit longer. And then post-transplant, we want this to be the longest period in your journey, and that's really something that you can have an impact on. Like I said, communicating with your team, following the recommendations, really doing what you need to do to take care of yourself, staying active, following a healthy diet after transplant, keeping your heart healthy. All those things can give you a longer time with a healthy kidney after transplant. Next slide. So just so that you know what we're looking for before we schedule you for a transplant, the criteria for us to schedule an appointment is for people, you can, be evaluated before you start dialysis. As once your GFR is, or the glomerular filtration rate is 20 or below, we're happy to evaluate you. If you're already on dialysis, that's, we'll be happy to evaluate you. We want you to be a healthy body weight. We do have a body mass index criteria of 40 or less for the evaluation. We really recommend, a little bit lower before the time of your transplant, and then not requiring oxygen, supplemental oxygen on a regular basis, because that can be a risk, during the surgery and trying to, extubate and things like that. So that's something we want you to be, able to, do your daily activities without needing supplemental oxygen. One other thing that is not on this is that more recently, our doctors have really had a requirement that they feel is very important, and that is to not be an active smoker. So if you do smoke, we would like you to quit smoking for at least 3 to 6 months before we start your evaluation. Next slide. So this is the kind of things that we look at during the evaluation to see, who do we think, is going to be healthy enough, and, have the lower risk so that they will have a successful transplant. So we're going to put you through a medical evaluation, some testing, maybe see some specialists, those kinds of things, do some blood tests. And then also we're going to have you see our social worker, and they're going to discuss with you, who's going to be on your recovery team, who is going to be helping you after your transplant. And also looking at, we do look at, how well you're doing on dialysis. Are you following the recommendations of your nephrologist? Are you completing all of your dialysis treatments? Or maybe do you miss one here and there and, not let the team know? Those are some things that can be concerning for us. So we'll take a look at, all of that. And you'll need somebody, you can't do transplant by yourself. You're going to need help. And we want you to have somebody who can be with you for at least the first month, 24 hours a day, 7 days a week, so that you have a backup. So they can come with you to your clinic appointments, help you with transportation, know all your medications. And when you go to the doctor, it's important to have that kind of advocate with you, because sometimes you get a lot of information and it's hard to remember everything. So, we think it's very important to have that person there and have somebody at home that knows, what's going on and can help you remember your medicines and those types of things. Also, the first month you're not going to be driving, so you're going to need somebody to help you with, transportation to clinics. And if you need to go to the emergency room, going to the grocery store, those types of things are why you need that help after transplant. Next slide, please. So not just, the help and being a good, healthy enough medical candidate, but we also want to make sure that, once you get your transplant, that you can afford the medications, you can afford your co-pays, and what's required for you to come to and from the clinic. So we do have, an authorization process. They look at your insurance, what your co-pays are, and help, if your co-pays and your shares of cost are really high, they'll help you look at alternatives. Also, to look at what some of the other costs may be. Parking. Unfortunately, UCLA, everybody has to pay for parking. Also, the price of gas if you're coming from far away, that can be a significant expense. So we want to make sure that you're thinking about these things so that you can afford the transplant. Next slide. Okay, so I think my colleague Bethany is going to pick it up here, and she's one of our wait list coordinators, so she's going to go over some information and give you a sense of the things that they want to make sure you continue, and what to expect and what kind of transplants you have for options. Thanks, Bethany.
Thank you, Jill.
Thank you, Jill.
Thanks. Thank you to the core group for having us. It's always great to be here to support the cause. As we transition into this slide, there are options for kidney transplant. If you have a living donor, that is the fastest way to get transplanted to move forward. You do not necessarily have to have a compatible donor. It just needs to be a donor that is suitable to donate, that's healthy enough to live the remainder of their life with one kidney. If your donor is not compatible with you, you can pursue paired exchange, where your person donates to someone that they match with, and someone else donates to you that is a match for you. Sometimes those turn into chain donations, where it creates sort of a domino of transplants that happens. Advanced donation is a unique option. Even if you are compatible with your donor, but if let's say that your donor needs to be your caregiver and you're incompatible by time, it doesn't work for you to both be recovering from surgery at the same time. Your donor in some cases can donate before you and designate a voucher for you so that once your donor is recovered and available to take care of you, that you can then await a match. The caveat to that program is that we can't ever guarantee that you will get a transplant if your donor donates, because we never know what the future is going to bring. So that is a piece of that that has to be evaluated honestly when we're looking at it for you. The other option to transplant is the deceased donor route. You can have directed donors if someone passes away and it meets the criteria to be a deceased donor, which very few deaths actually do. The family can designate you as a recipient of that donor, but in that case, you do have to meet compatibility requirements in order for that to work. You may be listed at other transplant centers, such as, say, Mayo in Arizona. It may benefit you to be listed at a program that is outside of the area where you are primarily listed. So for example, if a patient is listed at UCLA and they also go and get listed at Cedars, they're not helping themselves because the programs are literally next door to each other and we're pulling from the same donor pools. But if you are listed at UC Davis or Mayo or even UMC Nevada in Vegas, those are different donor pools or leverage from different locations, and that can advantage you and decrease your wait time to transplant. When we look at kidney transplant, we look at a variety of options. There's a metric called a KDPI, and that stands for a Kidney Donor Profile Index. And the important thing to note about that is it's not a score, it's not an absolute number, it's an index. And so it's a continuum that helps us understand quality of organs available for transplant. And the cutoff for a, quote, normal standard kidney is 85% on a 0 to 100 scale. And so those kidneys over 85% KDPI are not predicted to last as long in the recipient than their lower scored cohorts, but they can be a great option for patients who are older and maybe don't have a lot of life years in front of them. That's a perfect option for them. Patients who are not doing well on dialysis may need that as an option as well. Because we have great treatments now for hepatitis C, and we can cure the hep C virus, we will transplant hepatitis C positive donors into hepatitis C negative recipients. It does require a special consent in our program, and there are protocols that we follow if the recipient contracts the HCV virus, but it is an option and it's been proven to be safe. It's been in use widely in the United States for several years now. And patients who are of a smaller stature may be able to receive kidneys from small children that are removed in what we call en bloc. En bloc refers to the recovery process where in a pediatric donor, the kidneys and the associated blood vessels are too small to recover the organ alone. So the large vessels, the aorta and the vena cava, are recovered and the kidneys come out of the child in one piece. And so a recipient may get 2 baby kidneys. But there are risks associated with that. Surgically, it's a different risk operation. So it's only suitable for certain patients. Next slide, please. I'm not going to spend a whole lot of time diving into the content of this slide, but this is a website that was created by the folks over at Johns Hopkins, and it's a really, really great site to sit down and spend some time on if you are considering transplant and if you're considering certain donor options as you move through the process if you don't have a living donor. It's transplantmodels.com. It helps understand how long you may be predicted to live by taking, say, a high-risk kidney or saying no and remaining on dialysis. It helps predict mortality, and It's a really nice visual tool. It is a bit data heavy, but it's got a really great wealth of information, and the folks at Hopkins just did a great job. So I really encourage everyone to take a look at that. Next slide, please. So if you pursue living donation, that offers the best opportunity for kidney transplant. I apologize, I have a cat that entered the room. That will allow you to get transplanted the fastest. You can, as soon as your donor is available to donate and you've been found to be a suitable candidate, we can schedule surgery. Anyone that's healthy and willing to donate can be considered a living donor. And those donors complete an online intake at the website that you see on your screen. That intake takes about 20 minutes. It really should be done on a computer, not a tablet or a phone, because of the way the script on the page loads. At the end of the intake, it'll say, thank you for coming forward. Your intake has been accepted. And it'll tell you that you're going to get a call or an email within the next couple of days. If the intake is declined for whatever reason, if you're a potential donor, their BMI is a little bit too high or something like that, it'll say, thank you for applying. You do not meet our criteria, but if you want to talk to someone about it, and the email address is there so that the potential donor can reach out to our donor coordinator staff to talk about what they could do to be a candidate, or if it's not appropriate at all for them to be a donor. Next slide. So this is just a quick visual of blood type compatibility. In certain cases, we can use blood type A kidneys in B recipients, and in even a smaller number of cases in blood type O patients. That's because blood type A actually has two types. There's an A1 and an A2. And A2, the way that it makes sense in my head is A2 is sort of the wallflower at the party. It sort of pretends to be incognito. So if the recipient is a blood type B or a blood type O, and they do not have high reactivity to the A2 type, we can sometimes transplant those people with an A2 organ and not face any consequences. Next slide. So here's just some FAQs about living donation. All of the donor workup, evaluation, hospitalization, and surgery are covered by Medicare and or the recipient's insurance, because that donor kidney is the treatment for your kidney failure. Personal expenses such as travel and staying locally are not normally covered. There are some insurance companies offer reimbursement for that. And there is a living donor assistance fund that has pretty strict criteria for financial assistance for donors. It's an option that donor teams can help with that. But there are out-of-pocket expenses with living donation that are just inherent to the process that we haven't really found a great way to mitigate, but we're still working on it, and we would love more advocacy toward it. Donor evaluations really sort of take as long as they take. Donors may not be able to get to our campus often, quickly, and necessary tests may not be able to be booked easily. Every test that the donor goes through may result in the need for another test or another consult, so that we understand whether proceeding to donation is safe for them. But the average time to get through the process, if it's a fairly clean evaluation, is 3 to 6 months. Next slide, please. So your hospital stay, you're normally admitted the day of your transplant. Surgery takes 3 to 5 hours. Most recipients are in the hospital for 4 to 6 days. Could be longer if you received a multi-organ transplant, or if you are being transplanted for the second time or third time. Your hospitalization and your surgery are more complex, so you may be in the hospital for longer. The donors usually go home in under 48 hours. And if you take your thumb and you sort of put it on your hip bone and extend your middle finger down towards your pubic bone, the line that's created just a couple of inches above the fold in your groin, that's about where the incision is for a kidney transplant. We do not go into the area where your own kidneys are. Your peritoneal sac is pulled up out of the way, and the kidney is nestled into the hollow of your pelvis, usually on the right side. And the incision that's right there goes through fascia for the most part. There isn't really muscle tissue there. So it's a different type of incision, and it's not nearly as painful as some of the other types of incisions that you may have with other surgeries. Next slide. So being committed to the process we can't stress it enough. Once you receive the kidney, it's your newborn baby to take home, and there's no, there's no take backs. It's a big deal. You've got to take your medications religiously. You've got to be able to attend appointments and maintain contact with your transplant team. If you are a person who uses a little bit of creativity in the way that you take your medications, with regards to the way your doctor wants you to take them, I would encourage you to not do that anymore, because it's not going to go well after transplant. It's going to be a problem. And if the team finds out that there are things happening in the way that you manage your own care that are not in line with what the medical recommendations are, we may hold off on transplant for you, because we need you to demonstrate that you can follow the medical professional's directions to keep you safe and healthy after the transplant. And lastly on this, if your disease has just made you sick, and all of this is a lot, and it's overwhelming, and you don't feel like you can manage it yourself, you have to have a buddy. You have to have that cheerleader, that person that is your team coach, that is the manager of the appointments and the medications and the transportation, because there's a lot to do as you go through the evaluation, and there's a lot to do after you're transplanted. It does get simpler and you get used to it, but it never stops being a chronic disease that has to be managed. A kidney transplant does not cure your renal disease. It replaces the disease it replaces the function that your renal disease took. Is that the last slide, I believe? And here's just a few websites about some more information, and then the main line for our program. Thank you.
Wonderful. Thank you so much, Bethany. This was amazing. A great overview of transplant. Today, there are quite a bit of questions coming in for the post-transplant, and I think Dr. Sarkar is answering them. But today we want to focus more on the pre-transplant, the transplant evaluation. And I think if all our panelists can come on the cameras, I'll stop sharing so we can all see each other. Nanette, Brandy, Jill, Dr. Sarkar, Christina. So one of the questions that came up, which I think is quite relevant and also probably summarizes what Bethany and Jill, and I'll toss that to Nanette. So Nanette, you can mention about your transplant process too, but the question is, please share 3 key things you did to prepare for your pre-transplant that helped you the most. And you can do more than 3 things, but the question was 3.
Sure, thank you. And thank you both to Bethany and Jill. That was a lot of really important information. So thank you for your presentations this evening. 3 things that I did. One, it was really important to me to have a preemptive transplant, meaning before I needed dialysis. So it was really important to be my own advocate and to really get the support in helping to identify a living kidney donor. So I think that was the first, was being my own advocate and getting my support team in place, outside of just my husband and my children, other people, creating a kidney community, as I would say, those people that really could advocate for me, support me throughout the process, both emotionally as I prepared for my transplant, and physically, as Jill and Bethany said, after that transplant. So really building a kidney community to support myself and my family, and then really getting to know my providers and what those expectations were going to be. Because as Bethany said, you know, the transplant is just the beginning of managing or continuing to manage what was for me a chronic illness over a long period of time. I had polycystic kidney disease. So, you know, really getting to know my providers and who my team was going to be once that transplant happened, and who I was going to be leaning into for that support there. And I was really grateful for the team that was available, and for Dr. Rastogi, who I have worked with from a research patient 12 years ago through the transplant process till today. So that team is really important.
Great. And also, Nanette, few things that you did not mention. You took care of yourself, and I think that's what Bethany and Jill were going over. And I do want to bring that out because you mentioned you have PKD, more specifically ADPKD. It's an autosomal dominant disease, in which that means that if you have a gene, you have the disease, right? It's not autosomal recessive. And so there's that, and we just have to accept there are drugs, that medications, but still, and you were on the trial, you were on the tolvaptan trial, and you it still progressed, and but what you did, and I do know that for a fact because, you know, we communicate on a regular basis, but you took care of yourself. You know, you changed your diet, you know, always taking your medications, had the follow-up appointments. So the reason I'm bringing this up is it's not the fact, you know, that you end up with end-stage kidney disease, but it's also how you end up with end-stage kidney disease. And when Bethany and Jill were going over the necessity to be compliant or adherent with your lifestyle and modifications, it's not just because we're trying to watch you and say that, but it's also the fact your outcomes will depend upon that as well. And also, you know, taking your medications.
I agree with you, Dr. Stogie. I do think I had such a shorter recovery time. I was, you know, walking a mile in less than 2 weeks. I was walking 5 miles at the end of my first month. I think that was because I walked a lot. I ate healthy in preparation for my transplant. My mother passed away at the age of 58 from polycystic kidney disease while waiting for a kidney transplant on dialysis. My sister and I were both diagnosed young, so I was blessed to partner with her in both being a research candidate in trying to outrun this whole transplant thing, but also, as you said, the exercise, the diet, and the mental health, right? You really have to stay ahead of your mental health, because managing a chronic illness, facing something as heavy as a transplant, knowing it is going to be a lifelong, that's managing that mental health, as I know Brandy's going to share with us as a mental health professional tonight, is one of the biggest keys that allows you to stay focused and allows, you know, your physical activity and your eating also feeds into that mental health. So thank you.
Right. So Brandy, I'll come to you next about the mental health. But before I do that, I just want to go to, I think either Bethany or Jill. We got a question. I'm on dialysis, and I'm not sure what to do next, right? So how do I, you know, get transplanted? To whoever wants to answer.
If you have not engaged with your social worker at the dialysis unit yet, I would strongly encourage you to do that now. The social workers at the units are a great resource for you to help you understand which transplant center, the insurance that you have, might be the best option for you. And the social workers are well acquainted with what we need at the program for your referral, so they can help assemble that packet to get it to the transplant center that is best for you and your insurance, to get you started in that process. And Jill may have something to add as well.
What I would recommend is exactly what Bethany said. And if you're not having success with your social worker, you can refer yourself. So you can, you know, call our team and say, hey, you know, I want to get evaluated. I need, I have people call me all the time, and we work on a way to do that. It's always easier with the, if you have your provider or your dialysis unit, because they can just send us the information that we need. But, if you're not having success, we're happy to help you get things going. As long as you have your insurance information, we can start the process.
And I would be, being a medical director of a few dialysis units, I will say that's really the right approach. Some dialysis units are more proactive than others. That's just the way it is. So it's being your own advocate. The key thing, the first one would be, just like Bethany and Jill said, identify who your care team is in the dialysis unit. There is an assigned social worker, but just like all the healthcare providers, they all have a lot of patients to follow, and they sometimes have very little time, to be honest with you. But identify them, and if they have not already spoken to you about the transplant process, then proactively reach out to them. You can self-refer, like Jill said. You can also talk to your medical director at the dialysis unit. There's also something called the ESRD network that oversees all the Nanette mentioned a word called preemptive transplant, and I'll come back to that in my next question, which is going to be to both Jill and Bethany, is how soon can I get transplanted? But at this point with this question, which was a very important one, if you feel lost, there are a lot of resources. You can, at the minimum, just email core kidney at mednet. We will make sure that you are hooked up with the right. But the social worker is your quarterback for transplant in your dialysis unit. Now, since we're having that question, Jill and Bethany, the patient has gone to the transplant program. They've seen by you guys. What follow-up do they get, and how can the dialysis unit be more involved in making sure that they stay, if they're waitlisted, number one, or if they are going towards a waitlisting and there's still procedures need to be done?
Well, I can start with, we see you at the evaluation appointment. We'll give you a list of testing or, consults that you need to complete, and we will help you schedule those. And any questions you have, you get your coordinator's a direct number. So, if you get home and you just can't remember anything from your appointment, look at your paperwork, call your coordinator and say, hey, how do I'm kind of lost. So we'll help you. Once you're on the wait list, I'll hand it over to Bethany because she's one of the transplant coordinators.
Yes, my team covers you once you're waitlisted. So once you're listed, if you have a living donor, we'll shoot you to transplant as soon as there's a donor available and it's right for you. If you are preemptive, it may be too soon. If your GFR is still pretty high and you're doing really, really well, that's a discussion that you'd have with the physicians to time transplant. There is such a thing as going too soon to surgery. We don't necessarily want to do that and put you through the risks of surgery and the risks and side effects of the powerful medications that we use before it's really necessary. But if you're waiting for a deceased donor, the wait times in Southern California are very disappointingly long. So our patients can wait 10 years plus for transplant across the blood types. Pre-COVID, our wait times across the board were coming down. Things were going actually quite well. I was really pleased. I do the data for wait times at our program, and a number of things changed during COVID, including adjustments to the deceased donor allocation system. So wait times are back up to 8 to 10 years for blood type O, easily, into year 6 for blood type A for the most part, and 6, 7 for blood type B. What we're also seeing is that the algorithm is weighted a bit more towards people who are predicted to live a long time after transplant meaning that they have a survival score that is fairly low, and the older patients are waiting longer. I don't like it, but that's what the algorithm seems to be doing, and that's what's true. So living donation is always going to be your best option. A living donor transplant is always going to be superior to a deceased donor transplant. That doesn't mean that you can't get a deceased donor transplant that will last you the remainder of your life, but living donation is the best way. It's the best path forward. The other part of your question about staying ready, you know, the dialysis unit does a great job in connecting you with the transplant center, but they don't necessarily know what it is that we do. So if you go in the hospital or you change insurance, things like that, they're not going to let me know. They're not going to call me. It's very unlikely that anyone's going to let me know if you and your family don't. So staying ready has to do with keeping in touch with us at the program, touching base. Hey, I'm about to start dialysis. Just wanted to let you know. Hey, I'm changing dialysis units, I'm changing insurance next month, I'm traveling internationally, things like that. Just a heads up, if you're not sure if I need to know, call me and I'll tell you if I need to know. It's easier to give me more information that I don't necessarily need than for my call team to be trying to find you with a deceased donor offer in the middle of the night and they don't know where you are, or they just found out that you're in the hospital or something like that, and the opportunity's missed.
So Bethany, this is very useful, and Jill, because number one is the role of the dialysis unit as well. And a lot of times, you know, when patients are a bit lost, the social worker acts as a bridge between the dialysis, even when they're waitlisted. I mean, I have so many patients, they have no clue. You know, I ask them, what's the last you were told? Is there anything pending? So social worker, but at the end, your quarterback is your transplant coordinator, and I think that is very important. And I think the other important point is that staying healthy, and if there's any changes that you need to notify, whether it be insurance, whether it be your health, whether it be your contact information too, right? As simple as a cell phone that's changing, or how will they get hold of you if they get called? So I think all those numbers are very, very critical, or contact information. The other question that I think is, so at least at UCLA, the patients that are being taken, that are UCLA health patients, as opposed to patients who crash into dialysis and we take care of them. They're two different groups. I always try to separate them because they don't get the care that UCLA Health provides, you know, pre-dialysis or CKD care. And Nanette mentioned preemptive transplant. That means that you get a transplant, you bypass dialysis completely, and and most of the times you need to have a living donor for that as well. But let's talk about what's too early, right? You mentioned, and also Bethany, about when is the wait, the time that you accrue, when does that begin? That's a question that came in as well.
Okay. If you are not on dialysis and the day that you become listed for transplant is the day that you begin to accrue wait time. If you are on dialysis prior to being listed for transplant, your dialysis date is the wait date. The only caveat to that is the race GFR policy that took effect last year that grants wait time to African-American patients who were impacted by older, outdated GFR calculators, where we can modify the date. But if the listing date, is the wait date if you're not on dialysis, and dialysis date if you are on dialysis. And then to the question of what is too early, I think Dr. Sarkar was probably ready to answer that question.
Right. So before we get into that, your GFR is 22, right? And I think Jill mentioned, or you mentioned 20, right? But there's somebody who's 22 and they are sent to you and they're cleared, but they will not be listed at that time?
If they have a GFR that was 20 or below,
yeah,
at some point, it can be used for listing. But if you, we at our program does not list if people don't have a GFR that qualifies them to accrue wait time. You can be listed with a GFR that's higher than 20, but you won't accrue wait time on the list. And so our program doesn't do that. We don't list until there is a qualifying metric.
Mhm.
And Jill may be able to speak to what the timing of a good GFR would be to bring in for evaluation.
Yeah, we are requiring, I mean, that's just our cutoff is, we need to see that you're somebody, if we go through the evaluation, that you're somebody that we could list and get wait time. So right now our policy is that you need to have a GFR of 20 or less to start your eval. So, if you're almost there, it's a good idea to get some of your testing done and as soon as you're there, even sometimes if, you're steadily going down, we may make some exceptions to get you get you an appointment because our appointments we're scheduling a few months, from when we get your referral. Your appointment may not be for 2 or 3 months after that. So a lot of times, so that we don't disadvantage people because of our weights, that, we can look at something like that.
That's wonderful. I know we have so many questions coming up. We won't be able to answer all of them. I have a whole list. So, but because of time, but I do want to talk about something that's very important, and that is depression and mental health. Both Brandy and Nanette are leaders in that field. And before Brandy speaks on that, we want to mention there's something called the Kidney Care First. This is a program that UCLA is participating in, and this is coming from Medicare, the importance of depression screening. And even if you don't think you're depressed, or your family member or your loved one who has advanced kidney disease, screen them for depression, because number one, it impacts the outcomes. But the second thing is that being depressed, people don't feel good. As simple as that. So that's something that definitely needs to be addressed. So Brandy, I know you deal a lot with mental health issues.
Yeah, I think very commonly seen in someone who has chronic kidney disease or any kind of chronic illness, we see a lot of depression and anxiety. I think those two go hand in hand dealing with something like this, especially if you do have kidney disease that isn't at the point yet where you need dialysis, or you're not at the transplant point yet. It's almost like waiting for the other shoe to drop. So living with that anxiety can be very overwhelming. I do think that the best case scenario for someone is to have the coping skills in place, some of those de-stressors in place, and caretakers and family members and friends and some kind of network is the most important thing in this case. So if you don't have anybody like that in your life or in your corner, please reach out. There are programs available. The Core Kidney Program is one of them, but there are other resources out there and communities. You can find some on social media and Meetup and other places that can give you that support. But yeah, it's definitely normal. It's to be expected. There's nothing wrong with having depression or anxiety if you have this. It's just something that you want to get into check so it doesn't impact your treatment going forward.
And you're heavily involved with psychotherapy, and you have your own program that you run, but depression, and you also use the word anxiety, right? That's very common. And it needs to be actually, we're screening for that. The word is screening, because it might be there and you don't know it, or at least it's not obvious to the healthcare provider. Now, the Core Kidney Program has been very proactive about depression and anxiety. Our resident psychologist, besides Brandy, is Jim Cunningham, and we have done, I would say, a fairly good job. Nanette's, she's a very successful professional, and so is Brandy in the field of mental health. But I just want to reemphasize how important mental health is, because it's mind over matter at the end. And if and it's not just medication because people say they'll put me on. I would say, speak to your healthcare provider, speak to your nephrologist, speak to a psychotherapist, because a lot of times that can address a problem. As Bernie said, your friends and family members are very critical. So I think any passing comments by our team, Dr. Sarkar, I know you popped on, and your question was going to be about the early, but I think we'll save that for the next program. But anything that you want to add?
No, I mean, I just also want to emphasize that, you have to find people you really value in your life and you really trust. It may or may not be your family members, but somebody who can be by your side. Families can be complicated, and we've seen things in transplant patients. It's somebody who can really be your cheerleader during this journey. Like somebody who's there to hold your hand when you go to the ER, somebody who's there when you're down and the medication seems overwhelming. I just don't want you to latch on to that. You absolutely need a family member, somebody who's your trusted and a very reliable counterpart. That's what you need. You need a friend.
Yeah. And reliable is the key word.
Right.
So no, but I think once again, this is and COVID time, really brought this to surface even more in our patients. So I think, Christina, do you want to say a few words? And I know, and I do want to have a shout out to all our beans that have been running this program, our living kidney donors. I put those names in, our recipients. It's Kidney Month, so I just want to wish everybody a very, very happy March 14th, if I'm not mistaken, is the World Kidney Day. We were supposed to have some event that day. I'm not sure if we're going to have it that day, but we're going to have things throughout the month. And like I said, you just have to, address the problem and have a team that can help you fight it. And all the people who are here today, at some level, either they have themselves or their loved ones or their patients have fought this. So with that, I want to thank everybody. Anything else, Bethany and Jill, that you want to say? Final comments? And I'm sure you'll be back very soon because I have all these questions with me, the 3 pages. So I'll be answering them.
I'm going to ask a question both to Bethany and Jill, because I think a lot of patients have been asking this. Why are 2 donors not simultaneously evaluated when going in there? I mean, there's somebody who's sending me this privately right now too.
Actually, I don't know, Bethany, if you have
That
insight, but
that rule has changed.
yes. So we are
Oh,
doing it now.
yes.
We are doing
We
simultaneous.
will evaluate up to 3 at the same time right now,
Mhm.
Wow.
right?
Yes.
So when did this change, Bethany and Jill?
A couple
Ooh,
months ago, I think
yeah,
it was
fairly
probably,
recent.
yeah.
Okay. That's what. So 3. Wonderful. That's great. Thanks for asking that, Dr. Sarkar.
No, I think that's very important. Like this is great news for everybody.
Yes.
Mhm.
Yeah. But this program, I just want to thank once again. These are the experts. This represents UCLA Health. So everything that was spoken today, discussed, is vetted, scientifically accurate, and mainstream. So there's nothing. So if they have any more questions, please email us. Please celebrate March Kidney Month, Dietitians Month. I know Shima, if she's still on, and also our Social Worker Month. So with that, we'll sign off for now, and we will be sending out an email very soon for our next, because there is going to be a follow-up on transplant, probably 2 follow-up on transplants. One, and then the last one will be focusing on the post-transplant. I think there's a lot of questions about immunosuppression that Dr. Sarkar was asking. We'll also talk about immunotolerance that happens. And then the final will start with the living donation, and what can be done, the process itself. So with that, thank you so much, everybody. And thank you, our panelists, for being
Thank
such a
you.
wonderful job. Thank you very much.